Good morning, everyone. I'd like to thank you for joining us on today's webinar. Just a couple quick housekeeping items. For a lot of you, these sound very familiar. Your lines are muted upon entry, but we also suggest that you mute your lines as well. If you have questions about today's content or you're providing responses to questions being asked, we ask that you put those in the Q&A box. If you have questions, technical questions, having some trouble with sound or images or things like that, if you'll put those type of questions in the chat box, I will do my best to assist you with those. And with that, I am going to turn this over to today's presenters.
Hello, everybody. I'm Lucas Evans. I'm the Central Area Behavior Analyst, and I will let my partners introduce themselves.
Hi, good morning. It's Rita Cooper, Western Region Area Behavior Analyst.
Good morning. This is Melantha Witherspoon, Eastern Area Behavior Analyst.
So thank you all for attending today. I'm going to assume that most of you were in last week's session. Those of you who were not, let me just kind of give you a background about what today's purpose is. This was originally, the section that we're going to be talking about today was originally intended to be part of the first part of the training. And as a refresher for those of you here last week and a kind of an introduction for folks that are joining us new today, this is supposed to be a training about for new members of a behavior support review committee or a professional peer review committee. However, all the information that we're going to be talking about today and in the upcoming installments of our training are perfectly applicable or relevant or useful for people even if they don't want to serve in a professional peer review capacity. So again, this is the second part of the first part, so extrapolate that, of the training for new members of the Behavior Support Review Committee. It's all going to be really useful information for folks to experience even if you don't want to do professional peer review. Some additional housekeeping items that we need to get out of the way includes items about CEUs. So this again this training will count as continuing education credit. The same procedure that we used last time is what we're going to use this time. So this is going to be a refresher for you if you were here last time. If not, pay very close attention. So what you need to do is you need to check in now by sending in the chat box your name, your BACB number, and your email address that you want the CEU certificate sent to. Additionally, you will be required to respond to all the polling questions throughout. So this is going to be an interactive presentation. And in order to be able to say that you actively participated in the training and earned the CEUs, you have to participate in the polling questions. And then finally, when we're done with the webinar today, you have to sign out. And you can say, hey, signing out, or indicate in some way that you're signing out. And that way we have a good record and we have good confidence that you were participating through this distance format because we can't see you and we can't hear you. Did I miss anything, y'all?
No, I think you covered it all. Just as an aside, though, too, as Lucas said, if this isn't, you're not using this to be part of the Behavior Support Review Committee peer review process, this is great knowledge and information if you happen to have one of your plans reviewed. So pay attention.
Absolutely. And then the last housekeeping item before we actually get into the content, one of the requests that was made, or items to prepare for the talk today, was to have access to the BACB compliance code. And we asked for the task list as well, didn't we?
Yes.
Okay. So hopefully you everybody on the phone, specifically if you're going to be doing this for CEUs, have the task list and the compliance code in front of you. If not, there's still time to go out there to the website and find it.
And I'm going to ask, if you do not have it and you need about 3 minutes to access that information, to let us know that so we don't get started and you don't have the information. So please let us know if you need to access those documents. The compliance code and codes and the task list, let us know, please.
And then, Heike, do we want to mention about the Q&A versus the chat box?
Yeah, go ahead and refresh that. I mentioned that to them once, but let's do it again.
Okay, so Chatbox is for technical issues. Q&A is for content-related questions or responses. For your checking in and checking out, I'm not super concerned about it, but it just makes it easier for us to look at when you're typing it in, so that it cues us to know that you're asking a question about the content, or it cues us to know that you're having technical difficulties, and then when we're reviewing the data afterwards, it makes it easier for us to look at.
It looks like some folks need to access the compliance code and task list, so we'll give you about 3 minutes in addition to where we're at. I see everyone is following directions there, putting in their BACB number, and please, in addition, provide your email address. I see that some folks don't have their email address potentially, but you need your name, BACB number, and email address.
And then as we're waiting for folks to access those documents, are there any questions from the previous sessions regarding least restrictive that occurred to you after leaving last week's webinar that you want to kind of put out there? We would be happy to respond to them today, or at least think about them and respond later. Okay, so I'm going to assume that everybody's been able to access the documents that you needed. We're going to go ahead and get started. Since this is the second half of what was supposed to be one training, we don't have separate objectives for this one, so I'll run through real quickly what we any questions about how to join the peer review team we'll cover at the end of today, and we'll also include in the email that goes out after this. Also, just to say, I think Heike mentioned it, but I'll mention it again. So we will include a link to the recording of this webinar. You'll have access to the slides. You'll also have access to a frequently asked questions or kind of summary document that goes through what any kind of outstanding questions that were out there, or references that were provided. So we'll either send you the references or the actual literature, whatever we have available or is easier to do. And whatever is useful to you all. Okay, so to get into what we're going to be covering today, so the point of today really is to, first off, kind of define what a behavior support plan is, and you can see a slide about this. You've been looking at it for a while now, so hopefully you have some thoughts about it. And then to introduce what we consider and what literature generally agrees are essential elements for a behavior support plan, and then to look at how those elements align to different guiding documents, both professionally, ethically, and then kind of legally, and from different state and federal requirements. So that's really what our goal is today. So we're going to kind of walk through those. So let's start off by defining what a behavior support plan is. And you see I have this amazing graphic up here that I created. So you can see that I have a degree in graphic design because I've made this amazing thing. But hopefully you've been able to recognize that these are all 7 dimensions that are outlined in the seminal Bayer-Wolf-Risley article. And the way that I conceptually think about a behavior support plan is that it's the vehicle or the technological being kind of the foundation on that picture, through which the remaining 6 dimensions are kind of communicated or conveyed to the person and the team around the person getting services. So what I mean is that the behavior support plan is the vehicle or the technology through which we're effecting change on a socially important situation in a way that's based on science, that focuses on observable and measurable, it's consistent with what we know are basic principles of how people learn, and is effective not only in the specific situation in which the strategies are implemented, but also in other situations, current situations, and also that maintains over time. Practically what this means is everything that you're doing to affect change in a person's behavior kind of falls under the umbrella of the behavior support plan. So one way to think about it is everything that you would need to give to another clinician who's taking over your case would kind of fall into that umbrella of the behavior support plan. Now, this might be part of, attached to, or included in a larger document. So for example, if a person has an individual support plan or an ISP, the behavior support plan would be attached to it. If the person has an IEP, individualized education plan, it might be within it or attached to it. So I just want to make sure that we're having a common language around what we mean when we say behavior support plan, just so that when you all are encountering these elements, you understand where they come from and kind of how we're using them. We actually get to go to the next slide, Heike. Awesome. Okay, so this is me again. So the first element that we're going to talk about, and real quickly again, just to kind of ground us on where we're coming from. So these elements that we're going to be talking about are have been established in literature for quite a while. There's some different threads of effort that have kind of tried to define what an essential element would be. The original, or at least as far as I can tell, effort started with an article in 1992 by some folks called Vollmer, Iwata, Zarconi, and Rodgers being Dr. Teresa Rodgers, who kind of collected what they thought at the time based on what the current research said, based on what the current federal and state requirements were in Florida, what would be some essential elements of behavior support plans. Williams and Vollmer in 2015 kind of took a look at that original 92 article and again weighed in on what they thought were some essential elements. They were practically identical. And then, so this is mostly in the adult IDD system. This is where they were focusing their effort on. And then a separate thread of effort, but definitely related, came out of the school system. And there was a group of people in California, Browning, Wright, Mayer, and Sarin, who in 2013 released the kind of second iteration of their behavior support plan quality evaluation tool, which also laid out what they thought were essential elements for behavior support plans in a school setting. And then Ron Horner and Sagai also have kind of weighed in on what they thought needed to be in place in a behavior support plan in a school system. And then most recently, there's a behavior analysis and practice article from 2018 by Sean Quigley and some folks that really took a look at all of these different threads of effort and some additional articles that I haven't mentioned, specifically one by Tarbox that, and all of these references will be supplied to you all, but looked at kind of how all these things aligned and kind of delivered based on the literature what were some common themes of what should be essential elements. So the point I'm trying to make is that these essential elements aren't the Dr. Terry Rodgers in Missouri or the Lucas Evans, Rita Cooper, Melantha Witherspoon we think are a good idea. These actually come from some established literature. And then also you're going to see on each one of these slides, you're going to see boxes to the left and to the right of the element. And the boxes on the left are those guiding documents that I was referring to. So we're going to indicate how we think these elements align to task list items, ethical compliance code items, and for some of these slides, you're going to have some challenge questions where you're going to actually use the compliance code to decide which other ethical compliance code items apply to this element as well. And then on the bottom of the left, you'll see which one of the 7 dimensions of behavior analysis we also think is a focus. So by focus, I mean multiple dimensions would probably align with each one of these elements, specifically technological, because behavior support plan is a technological document. But this is a focus item of the focus dimension of the 7. And then on the right, you can see which states have similar standards. So they have standards defined in a formal way that also have elements that are aligned to what we do. So specifically Tennessee, who we've actually done some presenting with, Dr. Paul Malanga, and Tennessee, Florida, which makes sense because I just described how some of this effort originated in Florida, Georgia, which is a close relationship with Florida, California, I just talked about the BSPQE, and then also Utah has just recently come on board with elements that are eerily similar. Okay, so, no, go back, sorry, Heike. Fantastic. Okay, so item number 1. So this one is talking about that treatments provided based on a functional assessment. So really what the key part of this element is that we have identified functional relations for the behaviors that we're trying to change. So if you notice, it talks about specifically defining the functional relation for each target behavior. So features of a functional relation require to have an antecedent, the behavior that you're describing, and the actual functional consequence. So we're talking about functional antecedents and functional consequences for each behavior. So saying something is attention maintained or escape maintained does not meet those critical features that are contained in this element. So it doesn't even have the functional antecedent. So escape from what? Attention in what circumstance? And it also doesn't meet the functional consequence because attention and escape are categories of consequences, but not specific to that person and to that situation. So what kind of attention? Under what circumstances? What do you mean escape from what to where? So those are the things that we're looking for, and those things are absolutely necessary in order to be able to determine that the plan that follows really does kind of meet the identified assessed need of the person. All right, so here you get to actually practice. So again, hopefully everybody has a compliance code. So if you look at the first element is based on a functional assessment, we believe that compliance code items 1.05 section B, 3.04 and 4.03A all apply. But of the items that are on your screen right now, which additional applies to element 1? So 3.01A, 3.012, or 4.09, which one of those also applies for behavior support plan must be based on a functional assessment? So I give you 5 or so minutes to do this. We'll kind of just play it by ear to see how long it takes people to respond. I understand you're going to have to read these. That's kind of the point. So take a few minutes to do that now. All right, thank you all for responding. We had 100% of folks responded, so that's fantastic. It looks like the majority of people selected 3.01A, which would have been the obvious choice because it says we conduct assessments prior to making recommendations or developing behavior change programs. 4 people said 3.02, which is about the obligation to request medical consultation if it seems necessary. And so I'm interested to have some discussion around why you think that might fit. So I'm willing to be convinced, but that wasn't the one we chose. And then there was also 3 people who indicated that least restrictive, or 4.09, the obligation that we do least restrictive interventions, was aligned to needing to be based on a functional assessment. So I'd also like to hear some comments about that as well, because that wasn't one we chose, but again, we just kind of looked at it ourselves, so I would love to have some discussion around it. So let's start with needing a medical consultation. So could somebody kind of type in a response on why you think having being obligated to seek medical consultation would be related to needing to have strategies that are related to functional relations of behavior? Somebody responded only one answer was available. Correct. So yeah, we had only selected 3.01A as the one that we believe to be the aligned of the 3. But again, this isn't necessarily black and white. So if somebody has a good argument, I'm willing to hear it, and I'm perfectly willing to adjust my thought about what the right answer is. And
it's understandable that we always want to rule out any medical issues before going to function. So, you know, that may have been the rationale for choosing that, but help us understand, please.
Okay, so we had a response that said you would need to have medical information because that's going to affect how you're assessing motivation to engage in behavior. A specific behavior may function to obtain escape from the job, but only under specific conditions such as having a migraine. And I think all of those things that you said are absolutely relevant for the context. However, 3.02 is specifically about our obligation to ask for medical input when we think there's a medical problem. And so all those things that are mentioned about needing to understand the context, so the antecedent context, I think are still based on our assessment, but aren't necessarily related to our obligation to get medical people involved. Do my partners agree?
Yes, I would concur. Again, it's looking at having medical consultation if necessary. So if the person has a migraine or experiences migraines, then we already are aware of that.
Okay, so there are biological, which include physiological, neurological conditions that mediate environment and behavior. Again, that is true. However, those things still fit into the context of the situation and are not necessarily related to your obligation to get a doctor involved if you think there's a medical problem. So our obligation is, if we think there's a medical problem, we get medical people involved. But that's not necessarily related to, we need to make sure our interventions are aligned to the functional relations, including the functional antecedents. Okay, and then the last one is least restrictive, so 4.09. Does anybody want to offer some reasoning why you might think that the obligation to only use least restrictive interventions aligns with needing to be based on a functional assessment? Give about 10 more seconds. Okay, so we're going to move on, and just potentially we were not really clear on the activity. So what we're asking you to do is to look at the BACB Ethical Compliance Code and decide which one of these referenced items items of the compliance code align with the element that we're discussing. So we just discussed element number 1 based on a functional assessment. Those things that you see on your screen are the elements that we were asking you to determine whether or not they aligned. There was one answer that we had selected, 3.01A. So just so everybody's clear, apologies if there was some confusion about that. So let's move on to the next item.
And Lucas, I just want to piggyback off of what you just stated. Everyone should have a copy of the Professional and Ethical Compliance Code for Behavior Analysts. That's where the codes are listed. That's where you can verify what each code means. So we are on number 2 of the checklist, and number 2 wants to make sure that interventions align with the functional relationship in the BSP to include and address strategies related to the establishing operations, contextual factors, antecedent stimuli, contributing and controlling consequences, and psychological and medical variables. So when we all met and went through the BCB Ethical Compliance Code, we all agreed that 2.09 was in alignment with question 2, 4.30, 4.06, and so when we go to the challenge question, we want you to look at which other items apply.
Tell them to rule out 2.09 because that's a typo.
2.09 is a typo, so we want you to tell us if 4.07 applies or 7.01, and that's the next slide.
And we'll again give you about 3 to 5 minutes to be able to look at the compliance code and answer the questions.
Okay, so we recognize that there is a little glitch with the system, so we're going to ask you to put your answer in the question and answer box for us instead of responding to the polling question. Thank you guys for being patient. Okay, so number 2 is if interventions align with the functional relationship, the BSP includes ways to address the functional relationship described in the FBA. So making sure if the behavior is maintained by escape, you have strategies to address escape maintain behaviors. And again, with the challenge question 2.9, we want you to overlook that one and choose between 4.07A and 7.01. We want to know which other item applies, and you're putting it in the question and answer section for us. Thank you. It looks like everyone answered correctly, which is 4.07. If environmental conditions prevent implementation of a behavior change program, behavior analysts recommend that other professional assistance be sought. So great job, everyone.
So just to kind of tie that back to the question for item number 1. So item number 2 specifically looking at, are we acting in accordance with the assessed functional relations? So this is where we would act to get other medical professionals involved. And so it's kind of a subtle difference between element number 1 and 2. And one could probably argue that 1 and 2 really should be the same element. But we wanted to separate them out for the purposes of talking about it, and then we're looking at it to make sure that 1, we actually have a good functional relation identified, and 2, what is outlined in the plan to be done actually ties back to that well-identified functional relation.
Okay, so the next item, you don't have a challenge question, so breathe easy. You take a look at item number 3, and it looks at target behaviors, both desirable and undesirable. Clearly defined, measurable and observable. That means I see it, you see it, we see it, we all know what it is. This ties back to the task list item I-01, which again is defining in measurable and observable terms. The compliance code that ties back to this is 4.30, and that it aligns with unique behaviors and variables. So, and the focus dimension is, go figure, behavioral. And you can see what states we align with. So that should be pretty evident of what we need to do.
I think one thing that's really important in this element, and it's not by coincidence, is that it says undesirable and desirable are defined, which means that it's not good enough to just be focusing on the behavior and defining that one that we want to go down or reduce, that we actually have an idea of some other behavior that we want to increase. So it's both. You need both to meet that essential element and to meet kind of the underlying purpose of a behavior support plan, which is to make somebody's life better.
Thanks, Lucas, for mentioning that, it's the target behavior and the replacement behavior.
Yeah.
That is so critical.
All right, so element number 4, also not a challenge question, so awesome. This one is about having goals and objectives for how you're going to teach people skills or what they're going to learn related to the challenging situation that they're in. And really the takeaway from this one is, why are we doing this plan? What is the purpose? What are we here for? And how ultimately are we going to make this person's life better? And so unless you have a clear idea of what that is, so what do they need to learn and how we're going to get there, it's really unlikely that your behavior support plan is going to be effective. And it's also really, really unlikely that your behavior support plan is going to meet that applied dimension. So it's not going to actually affect change on a socially important situation, socially important for the person primarily, but also socially important for the people around the person. So this is really critical that we have an idea of how we're actually using these procedures in this plan and how that connects to making the person's life better. Did you want to add something? Oh, go back.
Once you have identified your goals and objectives, you want to make sure that there's data. There's a data collection procedure that ensures that data is being collected on the behaviors marked for reduction and the behaviors marked for increase. There's also the data collection system should include fidelity of implementation. When we are reviewing plans in the committee, we love to look at your actual data collection tool. And I just want to reiterate that data is important because it determines if your plan is actually working, if it's actually reducing the unwanted behaviors, and if the person is actually learning something that is going to be useful.
So, to tie that into what Melantha had indicated, not only do we want you to collect data, my goodness, we want you to graph the data. Go figure. You know, the idea behind those task list elements are truly the graphing of measurable items. The compliance code that we're looking at is 2.10A and B, which tie back to how you graph it, XY format. 2.11A and 3.04. When did the changes occur? They're noted on the graph. We see also that many of the other states also align with that. Utah didn't have anything that specifically called that out. But guess what? This is a challenge question. So let's take a look at it. And you might see these numbers being familiar because that was our technical glitch. So we want you to take a look at the compliance code 2.09A and B, 3.01A and B, and 4.30A. And we want you to do that in the polling section this time. So we'll give you a few minutes to look over that compliance code and go from there. All right, we're going to roll with this. So kudos to those of you who answered 3.01 A and B. You know, B part of that is the actual graphic analysis, and believe it or not, the assessment process is constant, or should be. So let's talk a little bit, if anyone wants to share why you chose 2.09 A and B and well, we'll just go with the 2.09 A and B. If somebody is willing to venture there and give us some rationale, we're open to it. It's always good to have these ethical discussions. I mean, an ethical discussion should be, as we mentioned in our last presentation, something more than, oh, is it okay to accept a glass of water when you're doing home programs? Well, no one wanted to venture out, so we'll give a response in regards to that.
Like...
I selected 2.09 A and B given the emphasis on graphing data display to determine effectiveness of treatment. You know, that I can understand your logic there, but it's truly looking at efficacy, and our focus is actually on the graphic display.
So hang on to that one, because we're going to get to that specific element that you're talking about, Alyssa, because, yeah, we think that's important too.
And that's part of our checklist. Any other items for, or other rationale for 2.09 A and B? Okay, so we had a couple folks choose 4.03A. Any discussion in regards to that at this point? Be bold. Okay. All right, so we're going to move on. 4.30A, you know, it does mention assessment results, so that may be why somebody truly chose that one. But again, we're looking at that graphic display. We love graphs too.
Well, our entire science is built on the visual analysis of data. So what this element is focusing on is that, is there that component? Is there that visual piece that analysis can take place? And there are additional items that we'll talk about, or additional elements that as we go through that would definitely benefit from having that visual display there. But it's critical that there is actual visual data displayed. Okay, so next slide, please. Okay, so element 7 is about having a plan specifically for how you're going to be proactive and how you're going to teach people stuff. And so really what this is about is, how are you making this person's life better? How are you trying to prevent those challenging situations from happening in the first place? Because, if we can prevent a challenging situation, specifically if it's a seriously challenging situation like physical aggression or extreme self-injury, we should do that. There's actually a really good Leaf article, a Justin Leaf article recently about how now it's time, based on our literature base, that we really start emphasizing prevention. And he's talking specifically about really not clinically based or based on a functional assessment prevention strategies, but I think it's still definitely applicable. We're really talking about prevention as really an important part of treatment. And so what are we doing to make the person's day more meaningful? So are we giving more choices? Are we increasing the amount of just non-contingently available reinforcement? So just in general, if you make somebody's environment more reinforcing, the likelihood that you have challenging behaviors is going to go down. And honestly, you don't even need to do a functional assessment to do that. There's actually a really good meta-analysis on non-contingent reinforcement that shows that you don't even have to have a functional reinforcer. You just make the person's life better and problem situations go down. So that's definitely an important piece. It might be removing unnecessary irritants or demands from the person's environment. That would be a proactive strategy. There's a procedure called demand fading that might fit in here too, where you're removing all demands right now and you're slowly moving them back in. And then that 7B is about what we're actually teaching the person to help them meet that goal that we identified earlier that makes their life better. So what are we teaching them to make their life better? All right, next one.
Element A focuses on strategies and specific instructions for reinforcement of desirable target behaviors. So Lucas talked about identifying skills that the learner needs to learn. So when are we, how often are we reinforcing the skill that the person is learning, and ensuring that the reinforcer is powerful enough to keep the learner motivated in learning, and the compliance codes that we believe that focus on identifying reinforcement is 4.03, 4.05, and there's a challenge question for this one, and we want to know which element does not apply. So you are going to simply select the element that does not apply.
And we threw you a little curve, so please bear with us. Does not apply.
Thank you all for answering. I'm going to kind of go through this a little bit and then ask for some input from you all. I'm going to go start with 4.08. In the compliance code, it says the behavior analysts recommend reinforcement rather than punishment whenever possible. So that kind of aligns with the question. I am curious to for those who chose 4.9 to give me some input as to why you feel as if that aligns.
Does not.
I'm sorry, that it does not align.
So least restrictive is not necessarily just about. All right, so sorry about that, folks. We were discussing it, and we've also had a little bit of a technical glitch. So we're back on. So when looking at the least restrictive items, so there was some questions about why people thought that did not align with having to have specific procedures for reinforcement and identifiable reinforcers. So you also note that one of those other items that you had to choose for was not using harmful reinforcers. So using a harmful reinforcer would actually be a more restrictive, not a least restrictive intervention. And least restrictive, remember, being the concept of ensuring that the strategies are the most like typical and least intrusive to the person, as possible based on kind of the person's situation and their history, and that doesn't necessarily mean just punishment. So a reinforcement procedure could be more restrictive, than a punishment procedure. For example, if you're using cocaine as a reinforcer, that would probably be more restrictive than another procedure. And some reinforcement procedures would be more restrictive than other reinforcement procedures. So we really do believe that the concept of least restrictive, so looking at the specific procedures in the context of the person and to recognize whether that this is the least restrictive strategies is necessary, as well as if you were to go on and say we need to have a more intensive response, which could include punishment, we're saying that reinforcement only has not been effective, and it's really impossible to meet that requirement if you don't have specific instruction. So any way that we think about it, we can't disentangle needing to have solid strategies for reinforcement from being least restrictive.
Thank you, Lucas. So let's move on to 9. So describe specific strategies, and the key is to generalize and maintain the effect of the plan across environments, fading of the contrived contingencies to more natural consequences, and that the support system these strategies are then faded. That's so critical. The task list generalization and maintenance to go to natural reinforcers. So let's look at those ethical codes, and this is going to be a challenge question, but it's a which of those would apply? So it's not a not. So 2.09 is specifically effective treatment. 4.05 describes the objective of the strategies. 4.06 is the success, and 4.11 is discontinuing. So the question then asks which other items do apply, and we're looking at 2.15 D1, 3.01, and 6.02. So we'll go back to what the question is and give you a couple moments to decide. All right, so thank you everyone for your responses. We're just going to go with kudos to all of you who answered correctly. 2.15D1, that is correct. And now you're going to ask me what it says, but that's okay. You guys read it, so we'll move on to 10.
Okay, so element 10. Now this verbiage, safety crisis plan, is not really Missouri specific, but it's the language that Missouri uses and some of the requirements that I'm going to mention. But really, it could be called a crisis plan. We call it a safety crisis plan. Could be called a reactive strategies plan. But the idea is that the behavior support plan needs to have a set of strategies or responses that are implemented in the event that a seriously challenging or high-risk situation or behavior occurs. So what do you do when things go bad? So what do all staff do? How do we know what to do to make sure we get through this situation as quickly and as safely as possible, and also minimize our chance for actually reinforcing the challenging behavior? If you work in the adult DD system, then you should know that it's actually a requirement for a behavior support plan to have a safety crisis plan within it. It doesn't need to be called the safety crisis plan, but the elements of the behavior support plan must include these, the features of the behavior support plan must include elements of a safety crisis plan. And again, it's just what you do when things go poorly. And then number 11, that Melantha is going to talk about is a little bit more in depth about the aversives that Alyssa was talking about a little bit earlier.
So number 11, if the safety crisis plan includes physical restraint or timeout, which in most cases physical restraint would be considered punishment unless a person is trying to access touch, and timeout would be considered punishment with the exception of a person that wants to escape a task or interaction with people. There needs to be specific criteria for those procedures when they're implemented. So there should be step-by-step instructions on how and when to implement those steps. And so when we go to the BACB Ethical Compliance Code, we agreed that 4.08, where the behavior analyst recommends reinforcement rather than punishment whenever possible. So if the committee is reviewing a behavior support plan that recommends the use of timeout, which has to be approved by Dr. Rodgers and reviewed by the Regional Behavior Support Review Committee, we're going to look at the behavior support plan to ensure that the plan that they used positive reinforcement, that there were specific instructions for positive reinforcement procedures, and that lots of strategies were implemented and were unsuccessful based on the data that is displayed graphically, and before we deem it appropriate to use any timeout procedures.
All right, so 12 shifts us to psychotropic medications, and if they've been prescribed, what are the target behaviors related to the reason why the medication was prescribed? The task list elements that we look at for this is bio and medical variables, that's G02, and then the effect of environmental variables on treatment, and of course, you cannot not consider a psychotropic variable as an environmental variable. It's really important. Ethical compliance codes, we're looking at, again, the effect and medical consult. So these are all important. If you have a plan and there have been no changes and the medication was prescribed before you got there, in the development of your plan, you can maybe inquire, get some more information. But definitely if psychotropic medications are prescribed in the flow of your plan, you need to note those, and you need to indicate on your graph data as a phase change line when that happened. There was a question, are BCBAs responsible for understanding behaviors related to medication prescribed? I think, you know, we all need, or everyone needs to understand what effects and side effects, because the MARS clearly called those out, and the med tech needs to understand. So I think being aware is really important. Are you responsible? I think you're responsible for at least understanding what medications do and what the side effects are.
And how they may affect your treatment program. If a person is on Depakote, and one of the side effects of Depakote is drowsiness or sleepiness, the person may be less motivated to get up and learn a new skill. Or if the medication is Abilify and it increases hunger, I'm just using this as an example, an M&M may be more reinforcing. So just understanding how the medication will affect the behavior support plan and your interventions is key.
So and we're not saying that behavior analysts should be doctors or medical doctors. We're not saying that people, behavior analysts or behavior providers should be pharmacists. And you can't know what you don't know. So we're not saying you look at a medication and you're just supposed to know how that ties back to what behavior is supposed to be effective. What probably it means is the conversation with the prescribing physician, psychiatrist, and saying, okay, why is he taking Ativan? Oh, it's to help with his anxiety? Okay, cool. Like what does anxiety look like for this person? So how can I know that his anxiety is better? What should I see or what should I not see? And those things can be tracked by the behavior analyst. And actually, if you go to the next slide, Ika. So the next element actually is that we're sharing this data with the prescribing physician. So the idea is starting to create that collaborative treatment team that's really important to ensure that we're getting good services. So any services provided in a silo or in isolation is probably not going to be nearly as effective as a team-based approach. And medication, specifically medication prescribed to treat mental health conditions or behavior issues, is specifically given to affect the person's behavior. So it is critical that exchange of information exists between the physician and the behavior analyst. That doesn't mean that it will always be possible. It doesn't mean that you're required to be a medical doctor or a psychiatrist. What it means is that we should be really concerned about how the medications that people that we're treating are taking and how that affects their behavior. And we should be looking at that when we're seeing the data move up and down to make sure that it's our intervention that's affecting the behavior and not some other variable like a medication change, like a side effect. So those are the things that are incredibly important.
Okay, element 14, if restrictive strategies are used, history and data related to the less restrictive positive-only strategies are described, and current ABA literature supports the procedures. So when we look at the compliance code, we look at 3.01, behavior analysts conduct current assessments prior to making recommendations or developing behavior change programs. It kind of relates to the discussion I had with about the use of timeout. We're just ensuring that we've tried the least restrictive interventions as it relates to that specific person, and that's documented, and that we have data to show the effectiveness of that strategy, or and that the journal articles support the use of the interventions that are being implemented.
All right. So item 15 is a culmination of a number of different elements on the checklist. And the goal of this item is to ensure that we have an improvement in the person's quality of life. And that's a really critical element. I'll review a little bit for you. Item 4 is indicating that we're teaching skills. If we don't have skills, we don't have a change in what the person can and cannot do. And that ties back to having replacement behaviors for the individual. Item number 5, data collection and the assessment and its effect on the behavior. How do you know it's affecting the person's quality of life if we're not actually measuring the behavior? Item number 7 is proactive strategies for teaching. Are we getting those antecedent manipulations in there? Are we actually looking at the environment? Item number 8 is, of course, reinforcement. And, you know, we have an obligation to go for reinforcement. I know people will say, but you can punish. And we are allowed to, and our ethical code does say we could punish. But let's get to the reinforcement first. And item number 9 is that we're generalizing and maintaining, that we go beyond the behavior support plan to those natural elements of reinforcement and motivation, that we're actually getting the person to the point where, my gosh, they may not need our services. And this aligns across the states. Utah didn't take any quick look at quality of life, but our other 4 associates in Tennessee, Florida, and Georgia, and California did.
Okay, element 16. So we're looking at, is there a description of how you're going to train staff in a performance-based method, or caregivers, or whoever's going to be implementing the plan? So the reality of the situation is, most of the time, at least in the IDD system that we're encountering, is it's not the behavior analyst themselves that is actually implementing the bulk of the plan. It's going to be a caregiver or a direct care staff or some other person. And so how does that person get trained up? If you are the behavior analyst and you're directly implementing, how would you train somebody else to do the procedure? And really what we're getting at is, are you putting the same care and thought into how you train somebody to do this plan as you are into the plan itself? So are we using behavior analysis, so what we know about how people learn, to actually train people that are going to be doing this, in addition to training the person on how to make their life better? Sometimes, specifically when you're talking about it coming into an environment that's severely deficient, and that a lot of the quality of life issues are related to environmental factors, you hear this joke frequently, and it's oftentimes true, is what you really need is a behavior support plan for staff. You really don't need a behavior support plan for the person, because if the staff would just do something differently, the person probably would behave in a way that would approximate what we would consider reasonable or appropriate. And so how do we train staff to do that? Another thing that's a huge ongoing issue in our current situation, especially if you're working with paid staff, is that staff turnover. So you might go in and do a training 1 month, and then next month you have all new staff. And so what's your system so you can efficiently train new people up? Stephen had a really great comment about using behavioral skills training. There's several, a lot of literature out on using behavioral skills training for staff and in organizationals. There's also been some research on pyramidal staff training and using behavioral skills training to kind of train coaches. So all those things are great methods for doing this, and it's really important that we're thinking about how we actually are actually communicating this plan to people that are going to be using it. So handing them a document and saying, okay, here's 20 pages or 15 pages or even 5 pages of the plan. Go ahead and read it over. Let me know if you have any questions. That's not training. We would not say that would be sufficient for the individuals that we're trying to help. That's not how we teach them, because that's not consistent with our science. Why would we expect a staff person to implement a BSP just by reading it?
Lisa had a question. Is there a mechanism for BCBAs to get additional funding to do more staff training? Well, there is a CPT code for staff training. So I don't know exactly what the cap on that is. I believe it's, and I'm not going to speak out of turn. I would have to actually check the CPT codes to see what that cap is, but you can train, and you can get paid for training.
So a specific question for you all would be, and this is going to be really important, not just right now. If you have some thoughts about it, that right now is fine. But going forward, so there is a specific code for, I think it's family treatment guidance is the code you could use for training. If you're using that code and you feel like it's not sufficient, so you're hitting the cap and you need more, that's something to definitely let the division know about, so that as we kind of look at how the max units available for that code are going forward, if there are ever any changes, we need to know that. And we're also looking at how it's utilized. So it's not just so people say we need a code to train, and it exists, but if people aren't using it, it's really hard for us to get a determination of how valuable that code is, whether or not it's enough. And so it's really going to be important for you all as you're using this code. So if you don't know about it, get familiar with it and start using it. And if you are using it and you're finding that it's not providing enough time to do training, let us know that so that we can start getting an idea of really what would be necessary or what's reasonable.
All right, moving on to element 17. After you have described the methods of performance, you have to have a system in place to determine how well the implementer understands what you have taught them. And so you're going to go in and you're going to measure fidelity. So you also are going to need to have a plan to address when the implementer is not succeeding in implementing the plan as written. So will you, as the licensed behavior analyst, go in and provide some more feedback, do some modeling? During training, did you video the implementation of the plan so that the implementer can go back and visually see how to implement the plan correctly, or do you pull the implementer out for a period of time and take them back through basic ABA and really give that person some one-on-one time so that they can implement that plan at least 100%? So 17 just focuses on making sure there's a system to measure if the implementer is implementing the plan correctly and what to do when the implementer is struggling.
So one thing, if you've met element 16, which is having clear procedures for how you train staff, it's going to be much easier to assess whether they're actually doing that with fidelity. So for example, if you actually have a task list or a checklist of all the steps that need to happen for the plan to be implemented correctly, you've already created your fidelity sheet. So you can use it both as a tool when training staff and also to ongoing assess whether they're doing it correctly. And then if you add a piece onto that you utilize performance feedback and then do some retraining, maybe using behavioral skills training, now you have a complete element 17 where you have a way to measure, assess, and respond to issues of fidelity.
The other thing that checklist provides is a cue card for staff so that they know they can actually, oh my gosh, do some self-checks. Did I do what I needed to on this part of the behavior support plan to actually implement it correctly? Wouldn't that be great if they could do some self-assessment, compare it to what you have? Wow, that would be awesome.
Very well said, Rita and Lucas. And so now we have a challenge question. We want to know which other item does not apply. So out of 2.09B, 4.07A and B, or 7.01, which one does not apply? And we'll give you a few minutes to answer. Okay, when we got together, we all agreed that 7.01 did not apply. You can be ethical and things cannot be implemented correctly, or things can be implemented correctly and you can be unethical.
Yep, absolutely.
And we can think of some great funny examples. You know, Lucas had mentioned one. You know, the Nazis were very good at executing their plan of genocide, but it sure wasn't ethical.
Yep, absolutely.
So we'll move on to item number 18. And item 18 is the description of how the plan will be communicated to all system support services for the individual. And I think we need to remember, who is that information shared with? It should be shared, oh my gosh, we might even want to share it with the individual. Wouldn't that be great if they could understand how they're making improvements? Of course, the guardian, the psychiatrist, the doctor. If there's an outside day program, you know, we might even collaborate and share information with the school, and the school might share information with us, and we might actually be addressing the same issues. And if somebody is actually working, because they might want to know. When we're looking at this element, the task list item looks at behavior services are documented. I think that's a critical element. We are ethically responsible to do that also. By the compliance code elements of 2.10 A and B to document your work. The other ones are to note that your treatment is effective and share that with others and to cooperate with others and to explain the BSP, and that's all those compliance codes. And of course, we want generality as that focus dimension because we need for this to be communicated across all environments and to all elements that interact with the individual.
Rita, I loved how you highlighted that the plan should be communicated to all systems involved, because sometimes a person is doing very well at the day program and they're not doing so well in their home environment. And as you stated, those strategies can be shared and implemented across environments, and a person can improve. So I love how you pointed that out.
Thank you.
Okay, element 19. So we've previously mentioned that assessment is a continuous process, and we've also previously mentioned that having data and having a visual display of data are critical pieces. 19 is where those things kind of combine and contribute to the demonstration that if you have a plan that's been implemented, you've actually made adjustments based on the response to the treatment. So there's two pieces in this. One, there is the analysis piece of, hey, is this actually working? And then there's the action piece of, okay, it's not working. What do we need to do differently? What's the data telling me? What sort of changes do I have to make in order for this to be successful? So that's a really key piece. And so if we're not ongoing assessing, if we're not ongoing analyzing data, visual data specifically, because our field is based again on the visual analysis of data. So we like, as behavior analysts, like to pride ourselves with not kind of wallowing down with inferential statistics, which, you know, they definitely can be beneficial at times, but we like to say, like, we don't use statistic, we use visual analysis of data. If you can't see it on the graph, it's not real. Well, then we need to actually put that into practice. So we need to walk the walk, not just talk the talk. So we need to have visual analysis of data. We need to be looking. When I see the progress on a behavior support plan for a plan that I've implemented, I should be able to look at it and say, oh yeah, this is working. And if it's not working, then you should see a phase change line that indicates that I've made a change, and then you should see data that indicates that that was an effective change, or additional phase change lines that indicate additional changes were made based on how things worked. So that was a long way to say that you need to analyze and assess ongoing.
Right, and those are definitely critical elements. So the last checklist item that we have is if the plan has been implemented with fidelity, The data is provided and indicates adequate implementation. So what we want to make sure is that we are truly taking a look at that fidelity and, my gosh, graphing the fidelity too. That would be an awesome thing to be able to do and to look at it. And if they're not meeting the level that we want, and what should that level be? Ooh, let me think. At least 80%. So taking a look at, do you know that it's been implemented with at least 80% fidelity? You should graph it and make the necessary changes in what's being done to increase that fidelity. And this is actually a challenge question. So we're looking at which other elements do not apply. And 3.07b, 4.06, 5.01, or 5.06b. And again, which items do not apply. We'll give you a few moments. All right, so we've got a typo. Thanks, Steve Swanky, for pointing that out. There isn't a 3.07. It doesn't exist. It should be 3.01. So disregard that first.
Or if you answered that one, we will accept it because it obviously doesn't apply because it doesn't exist. But,
yeah.
If
Good
you haven't
job.
already answered that, then look at the other three. Apologies for the typos.
All right, so we know some of you are actually looking through and thumbing through that compliance code because you realized there wasn't a 3.07. So good job, folks. We appreciate that you are actually reading the document. So that's pretty awesome. And it looks like the majority of the folks chose the one that does not apply, 5.01. So I'm going to, since I jumped the gun and this was Melantha's question, I'm going to help her, have her kind of take it from there because she is the element 20 person.
So 5.01 is behavior analysts supervise only within their area of defined competence. That really doesn't align with fidelity of implementation. And so that's why that is the most appropriate choice. It does not apply. We had some discussion about who fidelity data should be shared with, and it really needs to be shared with the entire team. If an implementer is struggling to implement the BSP as written, and they are really not receptive to feedback, then that needs to be shared with their supervisor. It also needs to be shared with a service coordinator who is responsible for ensuring that the service is effective. It should be shared with management of the ISL, guardians, as well as if there's an implementer who is, when you go in to monitor, if they're implementing it 100%, that should be shared with the service coordinator. You have a very strong staff in the home, as well as management with the ISL provider.
And so this closely ties into element 4.06. So there was several people that identified that one as not applying. And that one is about describing what conditions are necessary for the behavior change program to be effective. And I'll definitely would welcome some input for some folks to think about why that might apply or might not apply. But from my point of view, if you don't have adequate fidelity of implementation, you're not going to have an effective plan, and that really is a requirement for the effectiveness of your plan, and really is something that you should be extremely concerned about and should be identifying as a necessary component of a plan's success. And so if the plan's not being implemented with fidelity, that's going to be something that you should be tying back to, saying, look, this is what I said I needed in my plan to be successful with this person to address this problem. That's why it's crucial that fidelity is high for implementation.
And I love that you mentioned that, Lucas, because again, if it was decided a specific reinforcer be made available and it's not being made available, then how can you expect the plan to be successful? And how can you expect the implementers to do it with fidelity? So that kind of ends our analysis of the elements for the Behavior Support Review Committee checklist. So we want to open it up to any questions and give you a teaser, so to speak. We'll be doing this ongoing series.
One moment. So it looks like we just had a comment about, it says describe to the client. So I suspect that is probably a reference to the individual being supported, who I think should know about the fidelity of their plan, but also recognize that the BACB compliance code defines client as all of the people that are benefiting or being affected by the behavior change program. So if you're providing services to a person who lives in, let's say, a residential agency and is supported by paid staff and all those people around them, like, they're all your clients. So the individual themselves that you're working with is your primary client, but all those other people are still your clients as well, and you have responsibilities to them in addition to just the person that you're providing services to.
And also the regional office that is funding that. The behavior analyst has a contract with DMH. We appreciate your patience here. We're reading through some of the questions or some of the comments in the question answer box. So.
Okay, so let's see. Do we have any final questions? Looks like, is there an email or an Outlook calendar notification about attending behavior support review committees? In the blast that we send out after this presentation, we will include a schedule of when the committees around the state occur. So there are 3 standard committees right now.
Yes.
With one coming on board soon, I hope.
Yes, hopefully if we have lots of people interested in becoming committee members, we will start a 4th committee in the southern region in which contracted behavior analysts will participate by phone.
Yeah, and so right now our standing meeting, our committees that have been in place for a couple years now are in the central area, which I chair. Eastern is chaired by Melantha, and her and I will work together to chair the southern when it gets up and running, and then Rita chairs the western side of the state. I will speak for the central committee that we meet standard, and again, we'll send this out so you don't have to write it down, but the central committee meets the 3rd Friday of the month in the morning to review plans. And then when do you all typically meet?
We meet the 2nd Tuesday of the month from 12 to 4, the Eastern Committee.
And the Western region is the 3rd Tuesday of the month from 12:30 to 4:30. And Steve, I would love to have you participate. And, you know, you can participate in almost any region because we have the opportunity to do those committees by WebEx. So, you know, if my date doesn't suit you, then see if Lucas may need your support. So we're all pretty flexible in the process.
We had an additional kind of comment about client. So Alyssa smartly points out that it's a sticky situation if the BCBA is having to look at DMH staff and the person as the client. And yeah, I would definitely agree with that it's definitely a complicated situation. I think it ultimately is the situation because you really are responsible in different ways to all of those parties. So you're responsible to the person themselves because you're being hired to help them improve their quality of life. You're responsible to DMH because you're being paid by DMH to help that person's life. You're responsible to the staff because you have been hired to help the person improve their quality of life, which directly affects the staff people. So yeah, absolutely. So do you want to add something, Melantha?
And I am just wanting to reiterate collaboration, and that is why it is so critical when that FBA is completed to have all of those members sitting around the table reviewing the results of the FBA and expectations.
Yeah, and really what we're talking about is creating kind of a hierarchy of responsibility or need. So you have your primary client, which is the person, but you also have these competing obligations, and so it may even be helpful to visually map those out about who you're responsible to what, or who you should be primarily concerned about, but who you also have to be concerned about, because you also have to be concerned about so not just the Department of Mental Health, but also the Missouri Medicaid Accounting, whatever the C stands for, but the people that go back and audit to make sure that all your documentation and all your plan materials are up to reporting requirements. So it is an extremely complex situation, but it's really important to continue to have those considerations and making sure that you recognize that your plan affects a lot of people, not just a specific person. It looks like there's a comment about, is there going to be a revamped or updated form for folks wanting to speak with review committee? One thing that has been noticed as a member was there was an issue of not knowing what the problem was and what folks need help with. That's really good feedback, and yeah, I think that's a good idea. I think we should do that. I would love all of your assistance with that, so you should all join up and help us figure that out. Yeah, we definitely would welcome any ideas about how we could make the system much more efficient. so that we can not just help people that come through committee, but also better support the people that serve on the committee, so that it's actually a value-added activity for them, because the committee's volunteer, so we're not paying you. You're doing it out of the goodness of your heart or to your obligation to your profession, and so we want to make sure that it's value-added for you as well. So yeah, we're absolutely willing to consider any suggestions for how we can make that better.
Okay, if you have any more questions, please put them in the Q&A box as we proceed forward. We're getting close to the end of our 2 hours, and wanted to give you a kind of tickler out there. This series will be extended, you know, and we will have 2 WebExes next month on the...
Oh gosh, don't put me on the spot.
Oh gosh.
The date.
We don't remember the dates, but they will be, I think,
July 18th, I believe, is one day.
Yeah.
18th and the 25th.
18th and the 25th.
Yeah.
And what we will do is we will have gone through the elements this month, and next month we're going to see how we actually put that into work in a more detailed way, and doing some question and answer regarding each of the elements, giving you examples and non-examples, and then having you actually have a lot of interaction with each of those elements to indicate whether you think an exemplar or the item we put out there was an exemplar or non-exemplar. So be prepared for lots of interaction next month on the 18th and the 25th. We welcome you back.
You can also get more CEUs. Just going to throw that out there, and they're free.
Yeah.
And if you supervise people, please invite them to join this webinar. Again, it's just not for people who want to become a part of the committee. It's for anyone who wants to improve the quality of their services.
And also, you know, to learn more about, oh, that's how I could write that, or that's how I could include that, or that's what that looks like.
Mm-hmm.
So we look forward to you joining us next month on the 18th and the 25th. And we look forward to your feedback.
Also, don't forget to sign out. Thank you, Heike, for that prompt. Remember, one of the requirements is that you sign out before you leave, so go ahead and throw that in the chat box saying that you're signing out. You don't got to enter your information again. Just say, I'm leaving, or some sort of indication that you're leaving.
Ta-ta for now.
Yeah. See you next month, or there's no goodbye, there's only see you later, whatever mushy thing you want to put. We love it.
And we greatly appreciate you spending 2 hours with us today. And hopefully you've benefited from the information, and it'll help you to improve your plan.
Thank you.